Jeff, that was a great talk. We're going to talk a little about consultations. Brett? Okay, so you heard a little bit from Louis. I think the reception area is a very important area to capture people's attention. The Apple TV has been a great thing for me because if I'm doing something with a face, I've got the hair images rotating, and if I'm doing something with hair, a patient coming in for hair, they see my face work rotating and helps them think about the fact that I have other options that are there. I also, on the left, I put some candid shots of the staff and myself, and I think it's sort of a fun element so they don't have to stare at boring before and afters the whole time. You know, the person on the front end, you already heard from Jeff, is so important. That person answering the phone is so critical. And I get as many compliments from my staff as well as what I get, if not more. And I think what's really important, you'll hear tomorrow, I'll be talking about leadership and how to motivate staff. And the voice that you bring to your staff is what the voice they will bring to everyone else. I like the Ritz-Carlton idea of ladies and gentlemen serving ladies and gentlemen, and that's so important that you treat your staff right, because if you don't, you will have no extension of who you are and you'll have a miserable practice. Binders, I have a lot of these laminated binders in my office with a laminator that I do. I actually laminate all the before and afters and give my patients them to use as marketing material, but this is all my publications, thank you letters, speaking arrangement, brochures, etc. The setup of the room, so the dynamics that I've created is that I have, you heard from Amina, I have a mirror on the back. It's really nice if the patient sits back with their back to the mirror so they can just turn them around if I draw their hairline or show them their face. I have a little ruler to measure donor areas. I've got a little alcohol pad and a 4x4 to wipe off any lines that I draw. I have an eyebrow pencil that I use. I have, that's really great to draw hairlines with, by the way, instead of a permanent marker, clearly, if that's not obvious, it should be. I have a Mac with some of my before and afters. I love using the iPad, and at the ICHRS meeting coming up, I'll have a talk about how I use the iPad, and it's great to blow up hairlines and show corrections and to dance between before and afters, and it's also great in the post-op setting as well. Let's talk about how I build through the consult from beginning to end. First, obviously listen to what the patient is interested in, hear them out. What is their history? Where have they been before? What is their story? What are the things they liked or didn't like? And really take a good mental record of that before you start, because they could be interested in A and you could be way over in C. So give that time for their time to speak about what they're interested in. Touch is so important. You need to examine the patient. I really like to start with that because it gives me a good overview of what I can or cannot do. Once I draw a hairline, I look at the hair loss, I evaluate the donor, scars, scalp, elasticity, type of donor hair, density, curl, contrast ratio of their scalp to skin, scalp to hair. All these little things, the more experience you have, the easier that you sort of take an amalgam of all that information, and then you can input your thoughts about what would work for the patient, and it can guide you whether you're going to move toward medical management, incorporate medical management, what you're going to do, and that comes with experience, obviously. So I really like to start with a physical exam after a brief history, even before I start getting into what strategies I'm thinking about. And then I really go through the why. Why are you sitting in front of me? The goals and objectives. And I always try to frame it down so they understand this. And I always say, really, it's framing the face. So a lot of times if we're not, a lot of people come in for the crown, and I try to encourage them, if they've got a lot of frontal baldness, that frontal area may be very important, because it's an area that we communicate with one another with. And that framing the face, when I draw that line for them and show them the capacity to frame a face, I think it's so important to make that communication. And I say styleability, so that you don't have to comb your hair a certain way to cover the baldness. You can do a more modern do, you have more options available for you. So then also what I try to do is strategize short, medium, long-range goals. So a lot of people have this idea that a transplant can cover from front to all the way to back. And one of the easiest things I do to communicate with a patient is talk about numbers. So it's not number of grafts per se, but in the context of hair loss. So what I usually say to help people understand why I can't just cover the whole head with one session is that I say you're born with an average of about 100,000 hairs on your head, between 80 to 120. Each transplant session averages about 5,000 hairs. It could be 4, it could be 6, etc. And if you're going to take 5 and make it look like at least 50, it's not a one-to-one parity. So then the patient starts to understand, okay, now I get it. You have to artistically create that result. You can't just put what's gone and replace it. And so I start with that, they start to understand, okay, well then maybe a year from now, if my frontal area needs more, because you need 10,000 hairs to accomplish that, we could do that. Maybe we should go to the crown. And I outline what would be at a year, and then I project for them, just so they would know this, that they're going to need more sessions in the future. Whether that's going to be 2 years from now, 5 years, or 20 years, obviously I don't have a predictive capacity with 100% accuracy, but I can at least tell them, look, you're going to need more sessions. And if I don't outline that on the front end, I think I'm doing a disservice to them and making them, I think, have a misleading perception of what goes on with hair loss as further on. Oh, I also talked about limitations, risks of the procedure at that point. I start with the medicine before I go into surgery for a reason that Amina alluded to, is that I use it a lot of time as preparatory work. So they may have a lot of miniaturized hairs, they may have unstable hairs, they may need to go through time to see if they just are going to go through medicine before surgery. So I always introduce this strategically the same way, which is talk about medicine and how that's going to be important, whether it's going to be referrals to a dermatologist or an internist or someone else that can help me manage the patient in a preoperative setting. That's going to be important as well. So I go through some of the supportive or ancillary things before I go to the nuts and bolts. I talk about the experience because the experience is a black box, and YouTube has really been an amazing asset for me as well. It's a way to communicate with patients and walk into the operative theater and be with you. But there's nothing like the doctor spending a few minutes, or patient coordinator, walking a person through the nature of what the experience is like and really understand why you're different. If you have no clue why you're better or different from someone else, then you're really, the consult's a meaningless time with a patient. You need to understand that. For me, those selling points are that I take my time. It's a boutique experience. I'm in the room for 4 hours. I really love the design work. I'm the artist. I emphasize that element of how I shape a hairline, how I design the micro, the recipient sites, et cetera, how much care I take in the harvesting of the donor area. The fact that we have an accredited surgical facility that allows us to give you level 2 conscious sedation so there's no discomfort. I talk about how my techs and assistants are with me full time, and they're just as impassioned in your result as I am. So when you hear all of those things, you understand what your USP is. Find what your unique selling proposition is. If you don't have one, find it. I talk about the recovery. I always talk about potential telogen or shock loss afterwards too. I don't care who it is. If they don't hear that and they get some kind of shedding somewhere between 6 weeks and 3 months, they will be, I always say the difference between an education and an excuse is an education is told to them before they spend money, and excuses afterwards. After, oh my God, I didn't know that was going to happen. If you prepare them for it and it doesn't happen, you look like a hero. If you prepare them for it and it happens, you look like an educator. If you didn't prepare them for it and it happens, you look like a figured out. So I always go back at this point and reemphasize down the road, we may need a second session or third session, so there's no disappointment when you hit a year and you go, well, these little pockets didn't grow perfectly, or this area could have been a little better. They are understanding that's the nature of a hair restoration, that there can be areas that may need more. And then I talk about when it grows in, which typically, for me, it's on average about 6 months, where I would say 70% of patients are starting to see significant growth. Obviously, on both sides of that, you can have some good growth at 4 months. Some people need 9 to 12 months for growth. But really, for full expression, I say between 12 to 18, and now I'm really saying 18 to 24 months. Because as you get into the 18 to 24 and 12 to 18 months, what you're getting is something called asynchrony, which means that the hairs that are normally in anagen, telogen, catagen, that they actually grow and fall at the same time, will reestablish themselves into a normal asynchronous cycle. So they can even have waves of a little bit of loss even toward a year. Not commonly, but possible. And then I close. I'm now converted over to EMR, electronic medical records, so I do everything charting that way. I answer any questions they may have, and then I really talk about why I love what I do, because I really do. And I think it's so important that a physician not just stand there and be a dummy and just be a mouthpiece for what he does, but really be a own spokesperson for what he or she believes in. And I really believe in my product. And so then photos, I almost always take a photo of the hairline to document that, so the patient doesn't say, hey, you told me you were going to go low down here. I thought you were going to do my crown. We didn't talk about that. So I have the photos documented with and without the line. My staff takes care of that. Pricing, my patient care coordinator goes over. Samples and literature over platelet-rich plasma, things we'll talk about later that I use. Samples of finasteride, prescriptions of finasteride, et cetera, are done at the end after I step out of the room. I think is that it? Yeah, that's it. So, what's next?